The following content is provided under a Creative Commons license. Your support will help MIT OpenCourseware continue to offer high-quality educational resources for free. To make a donation or view additional materials from hundreds of MIT courses, visit MIT OpenCourseware at ocw.mit.edu.
And thanks very much for coming. And so I would say that I remember years ago Joy saying to me that when Paul Farmer was invited to talk and he couldn't go and she would go in his space, that it was always a little challenging, to kind of meet the expectations. So one thing that I think Joya really set well was encouraging people to really interact and to ask questions and to raise points and to, bring up issues that they themselves are familiar with. So I want that to be a way to actually make this lecture work as well, and hopefully going forward with the other lectures. So feel free to put your hand up and raise points, and we'll work around that, and that will, I think, be more exciting. So I'll ask a few questions as well, hopefully along the way, that we'll get some good answers from. What I wanted to do really was to follow on from what Joy was talking about, and I think she really did a great job of bringing up the challenges of providing healthcare in very resource-poor environments and all the difficulties and the huge problems that have to be overcome to do that, but also that one of the reasons why these problems have been so acute is that the policies and the strategies that have been used to support healthcare and to improve healthcare haven't always been well designed. And I think we've recognized that there are many aspects about the way that we've gone about trying to improve healthcare systems which really weren't suitable for the environments and for the communities that they were in. And this is a real challenge also for the use of technology and for information systems, that we need to be thinking very hard about what are the real needs of people on the ground, and then identifying where those needs relate to access to information as opposed to other fundamental issues like presence of trained staff, access to drugs, access to basic requirements of life like clean water and food and so on. And I think that there are a number of issues about information systems that are also somewhat dysfunctional in the way that they've been approached in resource-poor environments in a lot of countries around the world, actually even middle-income and high-income countries, and that's something that we're really interested in addressing. What I want to do is really talk about the importance of this question of where information access is a real challenge and where improving that can really make a difference to the quality of care. And in some ways there's sort of two sides to this, because on one hand we are looking at situations where someone might need to have access to, for example, laboratory data or the previous medications that a patient's been taking to be able to design their care or to diagnose that patient more effectively. There's also the other side, which is that you can't really do improvements in quality of care unless you can measure how well you're doing. You can't really ensure that the care is actually being provided and that quality is improving as you initiate different improvements. And so there's both the intervention piece and there's also the measurement piece. And these two interact in interesting and complicated ways. So, sometimes we may be really monitoring what's happening with other aspects of care, and other times the information system may be the main intervention. So I'd also like to do a little bit of review of some of the systems that have actually been developed over the last 10 years, a lot from my group and colleagues and friends around the world, and also other organizations and systems, and particularly to focus on evaluation data. And I think this has been one of the greatest missing pieces in a lot of the projects around the world, that although fairly large investments have been made, in fact, in some cases very large investments have been made in information systems, we really don't have a good evidence base for what is actually working and what isn't. We're getting it now, but it's taken a long time. So I'll kick off by talking a bit about global health informatics, or global e-health, which is the other term that people use a lot. I'll talk about the EMR system in Peru that we developed, the Partners in Health EMR, and then talk about OpenMRS as a platform and how we've actually used that system in Rwanda. And I'd then like to review some of the other e-health projects and lessons learned from these experiences over the years. Oops. So what was the original problem that was set when I started with PH just over 10 years ago? It was really, the question was, can treatment of HIV, and in this case particularly drug-resistant TB, be delivered in settings with limited or absent infrastructure? And so I think Joya really went a long way to addressing that question in terms of how do you design a system that will work to provide ambulatory care for MDR-TB and to get the prices of drugs down and so on. But then the question was, how do you then scale that? So when I started, there were maybe about 100 patients who'd been treated in Peru for MDR-TB or who were on treatment, and we wanted to aim for tens of thousands of patients. So how is that the same? Is that just a case of incrementally increasing what you're doing, or is that qualitatively different? And do you need different systems? And I think really the argument made then, and I certainly would support that now, is that you cannot treat 10,000 people in the same way you can treat 50 or 100 people. You need a different way of doing things. And so information systems are one of those pieces. The other thing we wanted to do was to scale this system to many sites and also to expand it over time so that it became a long-term project with many new people working on it, rather than just a small core group of enthusiasts who'd really kind of designed the original system. And we needed to do so to ensure that there were good outcomes and that the cost was manageable. And I say manageable, leaving it somewhat vague so we can come back and talk about what that means. One of the interesting things when we started was that people thought we were basically nuts. The idea of doing information systems in Haiti or Peru or Rwanda, people really said, you guys are crazy. I think that was the Clinton Foundation, actually. And so we had a slide which we used to show people for a while until they eventually decided that maybe it wasn't such a bad idea. Over the last couple of years, we've really seen a big change in kind of people's thinking about this. It came a little bit from a whole series of developments that are going on, such as the need for better global health delivery and a recognition that the delivery process for care is one of the key problems that we face. That there are technologies and there are approaches to healthcare and tools and drugs and so on that will allow everybody in the world to have a decent quality of life. But most people, or a large portion of people, are not getting full access to that. So delivery is a critical part of it. There's also obviously increased funding for global health, particularly with the Global Fund and PEPFAR and other agencies recognizing, with epidemics like HIV and MDR-TB, that there needs to be better investment in both the direct care, but also in the systems and the infrastructure. And then there's also, fortunately, better, lower-cost technologies, more robust, low-power, easier tools to use than when we started. And one of the things that kind of spurred this off was probably the meeting in Bellagio about 2.5 years ago, which was hosted by the Rockefeller Foundation. And we ran a session on electronic medical record systems and looking at how these systems could actually be improved and scaled in developing countries. So you've heard a little bit, quite a good bit about Partners in Health last week. And I just wanted to quickly review the PH model of care and how that fits with the way that we've been working with information systems as well. So first of all, of course, we're focused on access to healthcare to all people, whatever the situation or environment. We also look at the question of how do you create long-term partnerships rather than just one-off projects that maybe last for a year or 2 or 3, but actually really building these relationships and working with communities and training people and handing over all of that management as the project grows. Clearly, we have a big focus on community healthcare workers and building that community workforce within each different environment and training people and so on. And clearly, another piece that Joy talked a lot about was the question of addressing the various different causes of disease and the socioeconomic causes of ill health, such as lack of food, access to clean water, housing, and so on. And one of the things that I think is particularly relevant to my work is this question of bringing together both the elite institutions, academic institutions and medical schools and the technology that we have access to in a place like MIT with the lived experience of people in extremely difficult and challenging environments, and looking and saying, well, what are the things that we can do that would really help that situation? Not what is the technology that's worked in the US we can just plonk down there, but what are the real problems on the ground, and is there some way we could use to actually innovatively solve those problems? And I think that's the approach you really have to take. Think of, very, very driven by the problem, by the need, by the ideas of people who actually work in that environment. You've, I'm sure, seen examples of the community healthcare workers, and this is the accompagnateur in Haiti, the person who really walks with this patient through their health and through their management of their disease, providing directly observed therapy to the patient. And this is really one of the key interventions that has made such a difference in care for HIV and TB. When I started this work, I was thinking quite a lot about the work I'd done in the US and in Europe on management of chronic diseases. And this is really a relatively new field. So when I was doing medical school I wouldn't like to say exactly how long ago, chronic disease management was still kind of a little bit an ad hoc thing. There were people who knew how to do it, like the diabetologists, and there were other people who weren't so good at it. And heart disease in particular was not managed well in the community. And what we needed to do was to kind of look at a new model for managing patients. So what happened with HIV and drug-resistant TB, but particularly the whole HIV epidemic in Africa, was that suddenly we had to build a chronic disease management model that worked in developing environments, in very, very difficult environments. And the things you need to do there, first of all, you need to do case finding. You need to identify the patients. And this is still very challenging, and I'll talk a bit more about this later on. You need to make sure they start on the correct treatment. Now, if it's a simple case of HIV, I mean, if HIV is ever simple, then you would start on probably Trimune or some fairly straightforward treatment with one tablet. And that might be a little bit simpler than maybe treating a second-line case of HIV. If you have drug-resistant TB, well, you're talking a lot much more complicated treatment. The next thing is to ensure that there's a stable and economical supply of medication. And that turned out to be one of the really critical things that we've worked on over the years. And surprisingly something that retrieved incredibly little attention until the last year or two. And it's a huge, huge problem and a huge limitation to our ability to treat patients throughout the world. We need to ensure compliance of treatment, and that's something where the community healthcare workers, of course, are our critical technology, if you like, in many of the projects. And then we also need to monitor the progress and outcomes of these patients to ensure that they are, in fact, responding to treatment, to respond to problems that occur, either drug side effects or patients, for example, who have resistance that are not responding to the treatment they're on. So there are a number of core functions that we focused on with systems we were building. The first was clinical care and quality improvement. And this was, I think, really the core issue. We were not just interested in the kind of the public health approach of like what's happening, sort of in a community, sort of larger community or national level, but how do you actually address an individual patient's treatment? The next thing was monitoring and reporting, and so making sure that we could keep track of what was happening and also report to the government and to the funders. Drug supply management, which I said, kind of really suddenly appeared as a major problem originally in Peru, and also observational research, collecting data that could be used to understand better what was happening and how to improve that. So the first example that I started in, again, really building on what Joy was talking about last week, was the treatment of drug-resistant TB in Peru. And as she said, Peru had a particularly high instance of TB, and still does. And there were about 40,000 patients a year getting first-line or DOTS treatment when I started working there. It's a little bit lower now, but it's still pretty significant. And over 3% of these patients had drug-resistant TB. And this figure is actually hard to measure, and we're doing big studies at the moment to really try to measure that accurately. And these patients can require up to 9 different drugs to treat them. So it's a really complicated thing, and it's tailored to the sensitivity or resistance patterns of the organism that they have. So it's not just a case of standardizing this process. You really have to tailor it to get the best results. So what we did was we built this web-based medical record. It was based on some projects I was doing with Peter Solovich, one of the people who's running this course. A long time ago, we'd started working on web-based medical records. And so when I started talking to PIH about the needs of the Peru project, that seemed to be the right technology. People did think we were crazy to do this, but it worked. We started with basically dial-up connection for about a year. And the system was built in basically bilingual in English and Spanish. And then we've sort of scaled it over the years, and it's now got over 100,000 patient records in it. Over 13,000 have started or completed treatment for MDR-TB, and it's the national system for MDR-TB for the government. The system has a number of different key areas of data, particularly the smears and cultures and drug sensitivity test results, or DSTs. So remember this, we'll come back to this. This is the testing the mycobacterium to see which antibiotics it responds to. Other lab data like biochemistry, a kind of a registration form with a previous history and examination data and previous treatment. Digital images of chest x-rays, which we actually use a special protocol and digital camera for. And then drug regimen data, a very key part of the whole process. So having got this thing established, we found there were a number of problems. And so one lesson I think which I would like to kind of bounce out to you is, when things don't work, it's often an opportunity to do something interesting. It's annoying, it's sometimes dispiriting, but when you find a problem, it's often the time when you should take a step back and think, what's going on here? Because that's when you tend to find yourself innovating and coming up with interesting results. So one of the problems we had was that this bacteriology data was not very good. It was difficult to get hold of because in the area of Lima we were working in, there were 120 clinics, and about 60 of them did either microscopy for the smears of the mycobacterium, this is from the sputum samples, or they did culture in some cases. And so each one had its own little logbook and its own microscope, and maybe they had the incubator and a guy who was actually reporting the stuff. And the team would go around with their notebooks, they'd write this stuff down, they'd go back to the clinic, the clinic we work with, and they would then put it into a logbook, and then that would get entered into the EMR, and you can imagine it was just a really inefficient process. Probably an extremely typical process of what actually happens in many places. So what we said was, well, why don't we just use a Palm Pilot, download a list of the patients in the district, give that to the team member who was going to that site, and they could then enter into the Palm Pilot. And then when they synced that system, when they got back to the clinic, it would go into a kind of holding area where they could check the smears and cultures and make sure the data was in good quality. And then just that would put that into the main record. And so Joaquin Blaya, who was working on his PhD with me at the time, did this project. It was a little, really kind of almost like a trial project to kind of get started on this study that he was doing. But he turned it into a huge success. And what we did was to do an actual study of the impact of this system. And this was a design where we wanted to look at both historical controls and contemporary controls. So we looked at 4 clinics. We randomized 2 to early and 2 to late implementation. And then we looked at the pre-data and then the comparison data. And what we found was that in the original sites, it was about a month or so to get the data in, both intervention and control. And that fell a little bit over the year or so during the study to about 22 days, about 3 weeks. But in the intervention group, it was actually only 7 days, 7.5 days. And that was significant. And the other thing which was good was that the quality of the data was significantly better in the intervention group. And then we also found that the staff liked it so much, they kept complaining they wanted to finish the study and just use it everywhere. And they subsequently implemented it in new sites, and they also use it now for collecting patient weights in some cases. So the next problem was that the drug sensitivity test results were done at a number of larger laboratories, and Peru was at that point establishing a proper laboratory system for doing these DST results. When we started the project originally, all of the samples had to be sent to Boston to the Massachusetts State Lab. And so we would haul these things in multiple bags and containers and so on with CDC approval, but it was never a great process. And we had to bring them back to Boston to process. So as they established more laboratories, one of the things that came up was that they needed to more rapidly process the samples. So there was a study to look at more rapid methods for doing the DSTs, but at the same time it was realized there was all these problems with the information management. So 10% of the results took more than 60 days to arrive at the clinic after they had been reported in the lab. About a sixth of the patients waited over 100 days to start treatment. And these are sick people with probably multiple years of TB, and they're shedding drug-resistant TB and infecting other people. And then finally, there were a lot of duplicates. I don't know what that is. I suppose it seems appropriate, TB advisory. And so 17% were also duplicates, so they were wasting the resources. So what Joaquin did was to build a system called eChasqui. Chasqui is an Inca runner. So this guy is the little runner who takes the samples between the laboratories. And the eChasqui was established as a kind of a module on top of the EMR. And it included tools that allowed the laboratories to actually track the samples when they arrived, to do quality control on the processes and the samples, and then also to report the results to the physicians. And the physicians would then get an alerting email to say that there was a new result available. And so we then did a cluster randomized controlled trial of this in over almost 1,800 patients. And what we did was to randomize 12 clinics to the intervention and 22 to the control initially. And then that expanded as there were sort of sub-clinics in that group. And the study lasted about 1.5 years. So what was interesting was that, first of all, the intervention health centers had 82% less error rates in the DSTs and 87% less errors in the culture results. And this was particularly about missing results. So a lot of the time the error was that you just couldn't find the result in the patient's chart. And in addition to that, we found, for example, that in 66% of the controls and 55% of the intervention health centers, they were missing about 10% of the paper results. So this is really fundamentally a problem of just the workflow, of the access to data, and just the problems that occur with that. And so then we also looked at the effect on delays, and you can see there's a pretty significant drop in the delay getting a result from the lab. Now we're doing a lot better here than we were in the past. It's only 17 days, whereas you could see before there were a lot higher numbers. So things were getting better in general, but the system did improve things in both cases. But what was also interesting was that there was a significant reduction in the time to culture conversion. And that's really a very key clinical endpoint. Now, I'd love to say that everything lined up perfectly and that the time that the patient started treatment was shorter and everything, but the treatment start time was very variable, so it was hard to really get a clear signal on that. It didn't shorten very clearly, but the culture conversion time was significantly shorter, so it did seem to improve the way that the process was actually managed. Question, David?
What does culture conversion mean?
It means that the patient who has TB is when you actually take a sputum sample and you grow it in the lab, it will grow the bacteria. And that means you're culture positive. And so when you get started on treatment, when that person goes to culture negative, it's a critical event because it's one of the key milestones in curing that patient. And it shows that the treatment is actually working. And what you do is you take 2 samples a month apart, and if both of them are negative, then the date of conversion is the date of the first one. And so it's kind of a key event that we monitor. So, having done a lot of work on this particular area of MDR-TB, and also worked on an equivalent system which we built for HIV management in Haiti, we kind of recognized that there were some real issues around having specialized vertical systems, and we needed to think about doing something that was more kind of general purpose and could apply to lots of different kinds of diseases. So we needed really a system, an EMR system or an electronic medical record system that was simple to set up, that would work on multiple computing platforms, Windows and Linux and maybe the Mac, and then subsequently on actually mobile devices. We needed local users to be able to modify the system, add forms and reports, and generally be able to actually customize it to their own requirements rather than being really dependent on outside expertise. And we wanted the system to be web-based, but also designed so you could run it on a smaller device, such as a laptop in a clinic, if you didn't have connectivity. It needed to support open standards, and these are really a critical thing, which we'll come back to, but things like HL7 or Health Level 7, which is a communication standard for health information between different systems, like, for example, a medical record system and a lab system. LOINC, which is a coding system for lab data, and SNOMED and ICD-10, which is basically a system for coding diagnoses. ICD-10 is used by the WHO and a lot of international agencies, and SNOMED and SNOMED-CT, which is the modern version of that, is used by a lot of US hospitals. And we also wanted the system to be open source so that we could share the work of development both with our colleagues in the US but also around the world, and that the ownership of the system would be then really handed over to everybody who used it. So instead of saying, here's some free software, but you have to ask us to maintain it, we'd really hand over the whole system and the expertise and the training to really develop and use that. So out of this came a system called OpenMRS, or the Open Medical Record System. The Open EMR and Open EHR unfortunately had gone at that point, so we had the number 3. But that was a system which was originally conceived by a couple of colleagues of ours at the Regenstrief Institute in Indiana, who are working with their colleagues in Ampath in Kenya, which is a project in Western Kenya, which I'll talk about more. And they'd been thinking about this and building some prototypes when we got together and we were talking about how we needed to build something based upon what we'd been doing in Haiti with the HIV EMR system. And so we decided to collaborate and to actually build a new system, which we started at the beginning of 2005. And this is a system which is designed to be very kind of open, both in terms of open source, but it also supports open standards. And it has a concept dictionary to manage the data, which I'll come back to. It's modular so that you can actually take the core system, but you can also build additional pieces of software and plug them into it. so that you can have people who have limited experience experimenting, trying things out and building new modules, and then as they get better at it, being able to really extend the system. It was released as an open source system in 2007. And that's kind of important because there's a lot of people who talk about open source, but when it comes down to it, it's really hard to get the source code. So I assure you, since April 2007, our source code has been fully available, and we're very, very passionate about that issue. And one of the things that people talk a lot about open source is, who actually develops these systems and who is responsible for dealing with problems and bug fixes and so on. So we have a core team of paid programmers, one of whom is here, Rita, who's been working on the system actually for about 1.5 years now in Rwanda, and doing some of the training of Rwandan programmers. And so that team really is responsible for managing a lot of the issues. But we have a lot of volunteer programmers now, both individuals and also some companies. So the concept dictionary is a simple idea with lots of very interesting and sometimes complicated manifestations. So the idea is that instead of having a database where you build a separate table for each different set of data, or say a new form or a new kind of lab test, you have a dictionary and you can enter new concepts in that dictionary. And they can be numeric, in which case you have a range of numeric values. They can be coded, as in this case, where what you have is the main concept, which is functional review of symptoms, and then a list of other concepts which are really like a drop-down menu that you can then code the result with. They can also be used for drug orders, and you can also enter free text in concepts. And the idea of this is that it gives people the flexibility to add and extend the system, but also it has other advantages, like you can develop a core data set, for example, for drug-resistant TB, as we've been doing, and then you can share that with other organizations so people are actually using the same codes, and you can clearly map reports and analyses between the different sites. So it's really an important issue. And this can then be mapped to other coding systems. And we've done this, or our colleague from Millennium Villages project, Andy Cantor, who will actually be talking later on in this course, has done this for SNOMED and ICD and other coding systems. The OpenMRS community is based around a mailing list, and we have this website. And this is us at one of our meetings with about 120 people, which we've had in South Africa for about 5 years in a row now, getting everyone together to work on the requirements of the system and also do a lot of programming. This is an example of then taking OpenMRS, which is a core system and a common platform for building EMR systems, and then actually focusing on a particular disease within that core platform. And so in a way, it's kind of taking a full circle. It's a platform which can support primary care, HIV, TB, heart disease, whatever. But in this case, we've customized it to make it easier for people managing MDR-TB patients to have the tools that they would have had in the old system. So you can see they have a list of reports here, and then you can search for patients here. And then this is an example that Mark Goodrich, one of the programmers in our team here, has been working on to visualize the data for MDR-TB. And it's sort of based on a long series of different experiments over the years with our other systems. You can see that you have the different lab results here. These are smear results for this patient. This is a culture result, which is positive. This is drug sensitivity test results showing resistance to isoniazid and ethambutol and rifampicin. And this is a timeline for the drugs, or what we call a drugogram, showing that the patient is taking this particular set of drugs during that time, and that there's no resistance for the drugs that they're taking according to this result. Another really interesting thing that happened after we developed this system for MDR-TB based on OpenMRS was that Amir Khan and his group in Pakistan, in Karachi, decided they wanted to use the system. So they took the system, they did a mashup, a mashup with Google Maps, and so you can then see all the patient locations in Karachi, and then the patients who are green, their healthcare workers have texted that they actually received their directly therapy within the last 48 hours. And then when you click on one of these people, you can pull up this record, which is from the OpenMRS system. It's another way of viewing the smear and culture results. So it's kind of an interesting mix, and this was something that they took on and were able to do. Because it was open source, they were able to take the system and customize it and build on that. So OpenMRS has been growing rather rapidly. Not all of these sites are clinical, but about a month ago we did a survey to see how many sites were definitely using the system for clinical care. And there are at least 24 countries in which there are projects using the system for clinical care. Many of these are development sites, and many of these we don't really know what people are up to. And last year, about 110 countries downloaded the system. So we don't really quite know who is doing what with those ones. Question?
And that's exactly what I was going to ask, if you're marketing it to them in some way, or is it just that they can use it and you don't really know who's using it and all of that? That's just the same question.
I mean, we wondered about having a system that asks you if you can sort of send a message back saying, hey, I'm running now. But it's, in a way, it's kind of a little bit, it seems a little bit like a sort of, keeping tabs on people.
Right. No.
So it's a difficult question.
Yeah. But if they wanted to, they could just communicate with you via the website. I saw.
Exactly.
Was,
And so what this is doing, this is actually East Africa. Here is Rwanda, which is where we have a lot of our sites. There's 21 sites there. This is Western Kenya, Eldoret, Uganda. Down in Malawi, we have a site in Nino and some other sites. Down in the east coast of Tanzania, Millennium Village Project sites in West Africa. And then if we look at Rwanda itself, which is where I do a lot of my work, you can see this is the border around here, Lake Kivu, which I had the good pleasure of being in 2 weeks ago. And our site, Rinkwavu, is just in this area here, near the Akagera Game Reserve. So we've been working in Rwanda for about 5 years now. It's a small African country with about 9 million people, very densely populated and very heavily rural, although Kigali, the capital, is actually quite rapidly developing, so it seems like it's better off than it really is. It achieved really rapid economic growth over the last few years, but still has really big health problems. These numbers are probably a couple of years out of date. I wasn't able to get the exact recent ones, which have improved a bit, particularly maternal and infant mortality rates. But there's still, as you can see, very high numbers for these two figures, particularly maternal mortality. And very low median income, even though you wouldn't think that when you're in Kigali. So currently we're using OpenMRS in about 21 health centres. We're actually expanding at the moment to another 5 or 10. These are sites that PIH is supporting with the government. In addition, we collect data on HIV initially, and now on TB and heart disease, and we're expanding it to primary care. We have about 16,000 patients tracked in the system at the moment. That number is going up pretty quickly now that we've started registering new patients in primary care. And we have a team of what we call Rwanda data officers who do the data entry from paper forms. And that's usually the way people are entering data into systems like OpenMRS. And many sites actually have their own servers now because the internet access is really unreliable and it uses satellite internet, so it's got a high latency. And so what we're doing is we have a system running locally, but then we have some tools for synchronizing that data to a central site so that in the background you're getting a copy of that data, and you're also pushing back the data on things like CD4 counts. And that's really important. So the lab data, which is really critical for managing HIV patients, is getting to the peripheral sites. This is an example of some really kind of alerts and summaries that we've been printing for our staff for about 3.5 years now. And these are generated, so this is a row, for each patient has a row here. And what we're doing is we're actually showing the most recent weights, most recent CD4 counts, and if there's a problem, we can actually activate an alert such as, this patient needs a CD4 count, is out of date. And this data is really important, in fact, in helping to keep track of things. Patrick.
I know that in Rwanda they have a model of performance-based financing.
Uh-huh.
So it's one of the best models so far. So to monitor performance, you really have to have a good information system. So what was the application of this program on the ongoing performance-based monitoring and everything that is happening in all Rwanda? It's national.
So if you wouldn't mind, I will actually come back to that in about 5 minutes, because I've got a couple of things I wanted to set that up with. It's a very relevant question, which we've actually been bumping into. So one of the questions we want to know was, how effective was the EMR system in supporting some key aspects of care for HIV patients? So Cheryl Amoroso, who is our project manager and leads the EMR projects in Rwanda, looked at this question about whether the physicians had access to the latest CD4 count. So the way they did this was that when you fill out a paper follow-up form, the physician is asked to record what they believe is the most recent CD4 count. And so then we looked at whether there were delays in getting access to that. So we said, why don't we implement this new lab system which will allow the laboratory to enter the CD4 counts more efficiently into the EMR system, and then that will drive them towards those alerts I just showed you, and see if that had an impact. So we looked at this question of CD4 counts that were done in the last 60 days that were not available or not known to the physician when they saw the patient. We found that about a quarter of the time they actually had an out-of-date CD4 count. Once we'd implemented the lab system and with the paper printouts, we got that down to about 16%, which is, pretty good improvement, but it's still not good enough, obviously. And you have to think about the kind of environment we're working in, all the different clinics, the logistics of trying to get between those clinics and to actually deliver paper and then manage it all. So the question then was, how do we actually improve that further? So what we did was then to set up so that the clinicians can actually look at a summary of the patients. So we have the summary of HIV patients, and several of the clinics now have access to this in the ID clinic where the HIV patients are managed. And what they see is a little summary here which has basically a list of any adverse events, recent symptoms, the drug regimen the patient's taking, in this case Triimmune, and trimethoprim sulfamethoxazole prophylaxis. And then here's some key lab data like the CD4 counts and liver function tests, and then obviously a weight and CD4 count graph. And this is kind of the core data you want and follow up for these patients. And one thing was interesting was that this week actually, or in the last couple of weeks, our colleagues at AMPATH, using the OpenMRS system, have just published a paper looking at the impact of their clinical summaries, which are very similar to the one I just showed you. And what they were doing was printing out these summaries and giving them to the physicians before they saw the patients, same sort of model. And so they then decided to choose 2 clinics and randomly chose one to be an intervention site and then the other the control site. And they looked at the impact of the computerized reminders for people who needed a repeat CD4 count to see if that had an impact on the actual behavior of the clinicians in ordering these tests and getting this data from the patient. And they found that in the intervention group, about 53% of the time they ordered the test, whereas in the control group it was actually 38% of the time. And then this being our rural Africa, the printer didn't always work. So when they actually did work, the figure was 63%. So that gives you a sense that there was obviously having a pretty significant impact on the decision-making process of the physicians. And I think sort of taken along with the work we did with the CD4 count access, you can see that there is an evidence base growing to show in specific areas how an information system like this can actually really have an impact. There's a lot more to learn, but one of the interesting things about this was that having the information system to collect the data does allow, in principle, you to do better performance-based finance assessments, and that's something which I think is going to be important going forward in Rwanda. However, when I talk about the primary care piece, they use the paper registers to determine this performance-based financing. So when we actually decided to do things electronically, we then had to scramble to develop a special report so you could print it out to make it look like the paper registers, otherwise they wouldn't give them the money. So one of Rita's colleagues is busy hacking away at that report at the moment. I think it's nearly finished, ironically. But in future, I think Rwanda will be interested in using these kind of tools to really improve that process, and I'm sure that will be a phase we'll go through. So one of the interesting things in Rwanda is that it's a country that has a very forward-looking approach to health information systems. So what they've been doing is saying, well, instead of just having a few different organizations come in and build medical records or lab systems or systems for monitoring evaluation for, I don't know, malaria or whatever, we want a national plan, we want an architecture, we want to think about what each of these different components needs to do, we want to approve ones that will really do that well, and we want to make sure that they interoperate and they are based on open standards. And this is really exciting stuff. I mean, it's the sort of thing we're trying to do in the US at the moment. But Rwanda has the advantage of being able to do this in a smaller scale, and there isn't the same degree of legacy systems, obviously. So there are good things about not having stuff. David?
At some point you mentioned how important or not important patient privacy is in the implementation of these systems?
I will do. I knew that someone would ask. It is a very big issue for us, yeah. I mean, I'll come back and discuss it in detail, but definitely this is a very important question, particularly as you start to scale and you have to start to have national systems. And so there are some real questions. So what's happening here, this is kind of like national level, and this is sort of like health facility level. So you have the EMR system, You have lab systems that you can link to using HL7. Pharmacy systems, and we're working on standards to link those to the EMR system. For example, sending a drug regimen from a patient to the pharmacy. There's radiology systems, and in AMPATH they have a simple PAC system that's linked to using HL7 to OpenMRS. And then we have various mobile systems. Of course, one here called Sano you may have heard of, and also ODK and OpenX Data, which can link data, either entering data or downloading data in some cases from OpenMRS. And then at this level, you have things like the national supply chain and Kamerwa in Rwanda. You have TrackNet, which is a national web-based system for doing aggregate reports, which we now have a prototype SDMX HD message, which is a WHO standard for sending reports automatically to another system. And then there's also this question of national registries, lists of patients, providers, terminology servers, and so on. And so this is kind of my view of the world, where the EMR is kind of the middle here. It's just my way of looking at it. I think that this is a good way of doing it, particularly in a health facility. Other people would view it a little differently. We'd be down here, sort of near the bottom. But this is an example of one of the models for the national eHealth architecture. Not necessarily the final version, but this is one where we're using a Canada Health Infoways data exchange layer to link all the different pieces, OpenMRS and TrackNet and mobile devices for healthcare workers and so on. And then all these different registries and birth registries and so on. This stuff has big implications for access to private data and who owns that data and who manages it. And I think there are a lot of unresolved issues. Though Rwanda is unusual in at least having policies around this. I think only 3 developing countries had policies in the last year to manage health information privacy. So it is a big issue. So one of the interesting things was that the government in Rwanda was interested in using an EMR system more broadly. And we've been talking and negotiating about this for quite a long time, I mean several years at this point. But they've decided they wanted to go ahead and use OpenMRS for the clinics and smaller hospitals. And we actually just started a plan to roll the system out. And I was in Rwanda a couple of weeks ago, and we had the first new government site where we actually rolled out the system, and it's now running. So that was exciting after, I would say, 3 years of planning. So that's making progress. Now, this is another critical piece of the overall process, and which is how do we actually ensure that there is a workforce who are not only have access to open source, but they can really use that in a constructive and effective way. And you can't just say, here's a big open source project, it runs on Linux, go ahead and use it. You obviously need to have trained workforce. And so what we found in Rwanda was that there were computer science graduates, but they didn't have a lot of hands-on skills. It was a very kind of theoretical course. So what we did was to set up a training program, and Rita was helping to run that program for the last year and a half, and to teach Rwandan programmers how to do really hands-on programming. We also taught them about medical information systems, taught them how to actually build modules in OpenMRS, and then we did lectures on medical informatics and about medical data and some of the issues around medical data. And this is our first group graduating, and this is Dr. Agnes, who is the Permanent Secretary of Health and a big supporter of this work, and Chris Bailey from WHO. And we've had another graduating class last December. It was actually 12 in that case. So this group of programmers are now actually working with a bunch of organizations, including the Ministry of Health and Partners in Health and some of our other partners in the country, and helping to actually build the systems that are being rolled out. So one of the things that the government wanted was to expand beyond HIV to registering individual patients. So moving from a chronic disease issue to actually registering individual patients using a touchscreen registration system. And this is something that we rolled out about 6 months ago in Rinkwavu, our sort of main site in the east of the country. And we're now registering several thousand patients a week, I think, at this point. And we started that actually in the new rollout site as well. So this is an example where this data, which is normally kept in 5 or 6 different paper registries, which are not synchronized and not organized, that's actually what's used for the performance-based financing. So that's the thing we have to then retro print. but it'll move. So I want to talk a little bit about some other information systems. The real inventors of this idea of touchscreen patient registration and touchscreen systems for use of point of care in developing countries is a group called Baobab, founded by a friend and colleague called Jerry Douglas. And he really pioneered this idea of teaching people how to use a touchscreen because it's much easier than actually teaching people to use a keyboard and a mouse. And they've registered hundreds of thousands of patients in a long way in Malawi and have developed a system for direct data entry for HIV patient records where the registration person enters the patient originally, the nurse enters the vital signs, and then the physician actually enters clinical data and prescribes the patient's drug regimen. And then finally the patient then goes to the pharmacy and they dispense from the system as well. And they use a printed barcoded label on the patient's health passport to link this all together so that you can actually easily pull up the record. And we're now using that for our sites in Rwanda where people are actually doing the registration piece. And in Malawi, we're actually also recording the diagnosis in a coded system, and we're recording drug regimen data. So this is kind of an interesting step forward. Question?
Yeah. Do you have any interest in, you say you use barcodes that you put in your documents, do you have any interest in using any kind of biological identification, like fingerprints?
It's a big conversation. I think having some type of an ID that people can pull up the record with and that they can easily, re-identify the patient is very helpful. I think that there's some reservations about having everybody use fingerprints, for example, or biological identification. I mean, there's some cost issues, though that's less a problem than it used to be. Fingerprints aren't as great in people who do a lot of manual labor and farming as they would be in somebody, who has, a fairly light sort of computer kind of job. So it's not as reliable as it might be. Some people are doing that. I'm not sure if it's a critical thing, but there are situations where it might be helpful. So another thing system which has been interesting, and again this was actually worked by, oh sorry, I cannot.
Find out, do you have any data numbers on the cost benefit of this project in Rwanda, and who is actually paying for this in Rwanda? Because I know it's going to be a bit capital intensive, and Rwanda might not be able to put all the bills by themselves. They have some kind of support from.
So the question was really, what are some of the data about cost benefit for these type of systems, and also who is funding this type of work? This actually is one slide which I'll come back to, which does have some data about cost benefit. But I think there is this kind of question, are you in a phase of developing and piloting and evaluating systems, or are you in a phase of rolling it out to multiple sites in a kind of a more production level? So I think a lot of what we've done in the past has been around kind of developing, really inventing new kind of approaches and developing those systems. So that tends to take a bit more time and more expertise. With the rollout in Rwanda, we're going to start collecting much more accurate data, because then we'll be able to replicate, what does it cost to actually replicate a site, as opposed to what it originally cost to develop the system, because a lot of the development costs, hopefully, because it's open source and because it's shared with other groups, is in fact kind of shared with other organizations and is available to people. I mean, it's an interesting question, because when you look at the numbers for what's actually been spent on health information systems in low and middle income countries, it's pretty big. In fact, I've been still trying to get the numbers for USAID and PEPFAR and the Global Fund. We know for the World Bank that currently approved projects over the last 3 or 4 years, but the ones that are actually currently functioning in low and middle income countries, they've spent more than $480 million on health information systems, and none of that's been evaluated. So we really don't know what those systems are doing. And the World Bank, to their credit, is actually beginning to start looking at that and asking that question. The numbers for USAID and PEPFAR and Global Fund are probably much higher than that. So we're talking billions of dollars. And the problem is there is really very little evidence as to what works and what doesn't, and what's been replicated. So I think your question is very timely, but it's, in a sense, what we're doing is relatively low cost compared to these projects. But we'll have to really try and understand what it takes not only to set systems up, but it's really the total cost of ownership. What does it cost to set the system up, to roll it out to a whole group of sites, and to maintain that over a period of several years? And then what does it average out to? And I think that kind of number is actually the critical thing, rather than, if you have an initial grant, can you set something up, but does that still work in 6 months or a year?
Like, the reason why I'm asking this is that in a country like I'm from Nigeria, like such intervention in the health record system will really do well to improve the southwest part of the country, the size of Rwanda.
Oh yeah, sure. Yeah.
Do you have any concerns or any factors that you might take into consideration when you're trying to draw from the pilot study like you did in Rwanda back to a larger country without limitations such as privacy issues like what you had here in the US? Any factors like that? Do you see any factors like that when you're trying to transfer this technology from Rwanda to a much larger African country?
Again, I think I'm going to sort of try and cover some of these questions sort of throughout the talk, but I mean, to particularly answer those points, I think, scale is definitely an important issue, and Rwanda has the advantage that it's relatively easy to get around. So it's easier to get some of the sites than it would be in a much larger country, potentially. There are several projects in Nigeria using OpenMRS at this point, and a couple of them are actually making a lot of progress now. So I think there is a sort of a foothold in trying these systems out, and so far that seems to be working reasonably well. I think the confidentiality and data ownership and security of data issues are going to be important wherever you're working. There's a kind of an interaction between, is there a legal framework in the country? Is there a policy framework for who owns the data? Do patients feel comfortable with that? And then the question also, do you have good technology and good training? Because actually really training, I think, is probably the most important issue in making sure that patient confidentiality is maintained. I mean, I think you can build a good secure system, but if people are sharing passwords or they're downloading stuff and not respecting that data, that's going to be the biggest problem, actually. So I think training of really users and data managers and data entry staff and so on, that's a really big requirement. And getting that piece right is probably the critical thing. So just wanted to highlight this particular project, which I think is really interesting. Martin Weary, who is the lead author on this, will be talking later, actually at the end of this month. So he's got some really great ideas and experience in this area. But I just wanted to highlight this particular project where he used a Palm Pilot, very similar to the way that Joaquin and I did this project in Peru. And they wanted to look at home-based, basically health surveillance. They have a team of people going to different houses in Western Kenya. And what they do is they collect data on patient registration. So say the family, the woman and who's the head of the household, and her husband and the family, and record all the different patients. And then also recording data on HIV, a TB screening test, vaccinations, and also maternal care. And what they found was that then they went to their sort of pilot phase was 14,000 households and 41,000 patients. So they're pretty serious about what they're doing here. And this is now scaling up rapidly. What they found was that 45% of the pregnant women were not known to the health system. So they didn't have a trained birth attendant. They were not registered as being pregnancies that might be requiring intervention or risk. And so very, very big issue, which is one of the things that's really causing problems in a lot of countries. And they also found that 61% of the HIV patients that they found who were HIV positive in their voluntary counselling and testing process were not known to the system. And that was one of the motivations for trying to do this home-based testing, because they realized there's this big unmet need for HIV treatment. And they found it worked really well, very few technical problems, high user satisfaction, very much as we found in Peru. And they calculated that over the 2 million patients they're going to visit, we have about a $300,000 grant, I think from Rockefeller or actually Abbott Foundation. And that will work out about 15 cents per patient. So that's actually not bad. I mean, it's hard to know what is a good number, but that doesn't seem like a bad number. Another system which I think has been important in Africa is the District Health Information System. And this kind of fills the same sort of role that the TrackNet system does in Rwanda, where it's at district and national level. It's used to really do reports and mapping of aggregate data from health facilities. And it was developed in South Africa by a South African and Norwegian team called HISP. And they have actually used it now in a number of other African countries. It's starting to be used in Rwanda, Tanzania, Kenya, I think, as well, and also in India. And what they found was that there were some issues around the way the system was being used and the quality of data. So one problem that came up was in a program called PMTCT, or Prevention of Maternal to Child Transmission of HIV. And these are really critical programs that are in place to prevent the baby from actually being affected by the mother. And there are some key data you need to have to make sure that this happens. So it's not only a monitoring process, but it's also part of the intervention. You need to know which mothers are HIV positive, so you have to test them in pregnancy. You need to start the mother on prophylaxis, usually in our case triple therapy, to suppress the HIV viral load. You need to get the woman into a health facility for the birth, and ideally you do cesarean section. You need to give prophylaxis to the baby. You need to test the baby with a heel stick, which is one of the things that Joya showed you last week, to record whether they're antigen positive. And then if they are, you need to start that baby on antiretroviral therapy. So it's essentially kind of 6 key pieces of data. And what they were finding was that the studies, I've seen studies where only 20% of the time did that actually work in South Africa. So it's really a terrible outcome. And so Kedar Mate, who's a former colleague and actually will also, I think, be talking here, did a really interesting study on 316 clinics in KwaZulu-Natal and the eastern part of South Africa. And they looked at the completeness and accuracy of the data for these 6 key data elements. And what they did then was to go to the clinics and actually look at the real data on the ground. So they did a real study where you look at the actual records and then compare that with what's in the system and do a proper formal evaluation of the quality. And they found that only 50% of the time were the data elements accurate, which they said is within 10% of the reconstructive values. And only 12, only 10%, start again. Only 50% of the time were they accurate, within 10% of the reconstructive values, and I think 12% of the time they had all the data available. So it was a very poor outcome. And what they found was there was no computerization in any of the health centers. So people were just told, give us the numbers, you have to go through the paper registers, you have paper charts, put it all together. There was no training, there was no proper supervision for that. So they were working on the kind of the dot-com business model. You know, you lose money on every transaction, but make it up on volume. And somehow, you know, if you have bad data in every site, but you aggregate it, it'll get good, right? I mean, it's almost like it's like a subprime mortgage idea, you know. If you don't control what's going on the ground, then clearly you are not going to know what's happening at national level. And it's one of the real fallacies of the public health approach to data, which I've seen over the years. And it's really been a disaster that people cannot, you cannot get statistics at national level unless you do the work on the ground. And it's hard work, and it's painstaking, and it requires a lot of training and so on. But that's the critical piece. And the other advantage of doing it on the ground is that people get to use the data locally. They get to see it. They get to benefit from it. And so this was really one of the key findings of the study, was that the DHIS would work if there was a way of actually collecting and managing the data at the sites, such as an EMR system. And another important study that just came out, which I think is one which would be good to talk about and debate a little, I think, in this class. This was published in The Lancet by Lester and colleagues about 2 or 3 months ago, and it looked at the use of cell phone SMS reminders for HIV patients in Kenya to encourage them to take their antiretroviral therapy. So it was really kind of a compliance with treatment type of study. And what they did was to send an SMS once a week, and then if they didn't get a response from the patient, then the healthcare worker would actually ring the patient, and they would kind of provide them extra support. And what they showed was that 61% of the patients who were receiving the intervention had good compliance compared to 48% in the control group. And they also showed that the viral load was better suppressed, and that was statistically significant, though it was kind of a borderline thing. But they did show that there was some impact on the actual quality of care of these patients more directly. So this is a really interesting study, and I wonder, has anybody actually read this study here? I'll have to change that. No one read it? So, does anybody know much about the numbers for adherence rates for HIV treatment in Africa? And I want to have a guess at what the typical rate would be for, say, a 1-year adherence rate for good quality care and good adherence. So there have been a number of studies looking at this and a few actual systematic reviews. And one of them looked at loss to follow-up rates. So that's obviously more serious, where you actually really lost touch with the patient. But numbers like 61% adherence rate is not very good. So in the success group, the intervention group, those figures are way worse than we have at PIH in any of our projects that I'm aware of. We would be looking more in the terms of 90% for 1 year, probably 95%. And these are, this is because the accompagnators are there every day. seeing the patient, ensuring they take the treatment. So this technology of the community healthcare worker or accompanitor is a very good technology for making sure that people get treatment and also providing support and encouragement and a communication channel back to the health center. So I think one of the things we have to do when we look at this study, which made quite a big splash, was percentage-wise it's improved things, and I think there's some lessons to learn from that. But this is not a good outcome. If this was one of PIH's projects in Rwanda, we'd be really upset if this was the figures we're getting. So, I think we have to be very careful with interventions. What is the best standard of care? And so this approach of not providing very close supervision to patients doesn't work that well. And I think it's an important message to think about. If we're doing quality of care interventions, are we really getting the best result? And what I would say with this is that there's two groups here. There's the pre-ART group, somebody you know is HIV positive, maybe from the VCT, from voluntary counseling and testing program, but hasn't started on treatment yet, either because there hasn't been time or because their CD4 count is high. And then there's the group who are on ARV treatment. So the pre-ART group are actually at risk of loss to follow-up, and they don't necessarily have a healthcare worker. And those are a group where having reminders and using an information system to track them is probably really important. But once people are on treatment, having a healthcare worker actually do the supervision is much better. So, I think this is an important lesson to think about. Now, people will say there are cost issues around that, but I think, the cost issues around having patients not take their treatment and get resistance. Question, David?
The SMS, it was just one direction, right? They didn't send confirmation back.
The patients were sent a text, and then they would have to say, are you good or you're not good? And so there was some kind of dialogue going on.
And of the ones who successfully completed the dialogue, the adherence is 61%?
The ones who received the dialogue, who are actually in the program, the other ones just had normal care. So the people who had an SMS message sent, who then were called by the nurse if they had problems and had that kind of conversation going on, they were the 61%. So I think it's just, an important cautionary tale. And also, if you look at the paper, the viral load is, they kind of sneaked in. If they analyze it a different way, it's not fully significant. So I think it's an important study, but it illustrates some of the difficulties of really understanding what works best here. I don't have a huge amount of time, so I think I'm just going to quickly go through the supply chain thing. I just wanted to emphasize that it's really important to have tools to monitor drug supply and to manage drug supply in different clinics. This is a system we used in Haiti for the last 5 years or so, and we actually track the stock cards in each of the clinics using a web-based system, and then people can order online. And this was showing that when we were implementing this system, that it actually has pretty low stock-out rates. We got it down to about 1.1%. Although with Haiti being such a difficult country to work in, it's gone up and down depending on access to internet and so on. But stock-out rates in many projects in Africa are in the 20 to 40% range. So it's a really key issue. And this was another intervention where a group called Frontline SMS, working with Ushahidi, which is a group in Kenya that developed a mapping system for community data, initially after the election violence, but also used for a number of other purposes. They put together a system to look at stockouts in clinics in rural Africa, and the patient had to text if they were prescribed a drug, and then when they went to the clinic's pharmacy, the drug was stocked out. So they would text a certain number, and that would then get mapped. And they used this to actually change the policy in the country and to get it in the press and to really change activities around stockouts and raise this as a really high priority issue. And I think it's one of the reasons why there's much more attention to stockouts and drug supply management in the last year or two. Just a few questions on lessons learned, issues and lessons learned. First is you really have to have good local leadership if you're going to make these projects work. So you need to know who is actually driving this, and what do their needs? What do they really want to get out of this? Not, let's do an EMR system, but we need this to get better access to lab data, or we need a summary here, or we want to implement decision support or guidelines, and how can we do that most effectively? We need to really emphasize the importance of individual patient records. So this whole idea of DHIS and all these sort of public health approaches that WHO and other organizations and schools of public health in the US have promoted for so long, that you just aggregate the data and people in the clinics, are just to write down the numbers for that week, doesn't work. lots and lots of data to show that these numbers aren't good enough. But the other thing is it's not useful because the people in the clinics don't get any benefit. They get no feedback, they don't get to use that information, they don't get to review the numbers. So I think it's really important that we have systems, even if they're simple systems, to collect data in health facilities. And that also probably applies to communities with cell phones as well. Another problem which I've seen a lot is this question where people, they treat forms like some kind of a sacred object. It's like this sort of thing, we've got the form, and now you need to computerize the form. And it drives me nuts. These forms, they grow, and everyone argues about it, and eventually say, okay, the form is ready. And you're like, what are you going to use this form? Are you going to collect data? And they're like, but why? And if you don't do it that way, you drive the whole thing by the form, then you build the infrastructure and the software and so on. But then at the end of the day, do you know if you can actually get what you need out of it? What you really need to do is to say, what are your goals? Do you want to look at access to patient data? Do you want patient summaries? Do you want reports that show quality of care? Or do you need reports to funders? Decide on your outcomes and then work back from that. Work on what are the core data set you need to collect to actually make that work. And define that core data set, preferably in agreement with other projects so that you can actually share that data. So this is hard to do, I have to say, but it's what we're trying to do with maternal health, for example, at the moment. And then the form then becomes an artifact that is generated to feed this thing. And it means that the data you're collecting is going to actually correspond with what your most important goals are. And what you have to avoid is the form vortex. You go round and round and round, and everyone's like, no, I want this, I want that, and eventually it gets bigger and bigger. And your 10-page forms, not good. Another thing is this question about local data use. So collecting data in the clinic or even at the community level in the village and using it locally. It's incredibly important because what happens so often is you have these things where they basically, the data is collected here and it goes into the center. It gets dragged in by everyone. And basically what you get is this sort of, centripetal approach, and you don't get the benefit in the communities. So you have to avoid systems that just suck the stuff into the middle. And the other thing is this question about the core data set. Once you've defined what your goals are and you've defined, we're going to focus on these particular important things that are actually going to impact on care, you need to defend that core data set and keep the core values. It's okay if someone says, well, I want to collect some extra data, I'm prepared to pay an extra person to do the data entry, and we'll add that as an extra form to the system. I mean, that's a process that's okay. But you need this core data set, and you really want to maintain it and keep the fidelity of that. And then when you do that, for example, with this maternal concept library, which we're working on with Jonathan Payne, who's actually part of our group, getting everyone to agree, this is the data we need for maintaining quality of care, basically tracking down pregnant women in the community, ensuring that they get a trained birth attendant, monitoring them for risk factors, that sort of thing. So basically, you want to have some way of defending this. So this is my friend here who defends the data set. Another thing you need to do is good tools for data management and building into the system tools to make it easy for someone to see, are there missing data items? Are there, discrepant items? Can you see if there's people are entering the numeric data into text fields and generally trying to make it as easy as possible to spot problems early. Another thing which somehow I've learned the hard way, but it doesn't seem to be that obvious. You don't want to be trying to do 10 things at once, none of which is quite complete. It's a really bad place to be. You don't want, all these things are almost ready. You've got to nail a couple of things. You've got to say, we're just going to do patient registration, or we're just going to get these lab data to the doctors. And we'll get that right, and we'll get it working until everyone's like, this is really great. It's only, one of the 10 things I want to do, but I really rely on that thing. If you're in that space, you have huge potential to build on it. If you're there where everything is not quite ready and everyone's putting all this work in there, collecting all this data and they're working hard, but no one really trusts the data, it's not a good place to be. And other fairly obvious but important thing, making sure you have good power supply and power backups, and also lightning protection and grounding. If you went around and measured how many sites actually had grounding in the clinics, you'd be surprised. It's very low and it's very dangerous. And it's also dangerous for equipment, but can be dangerous to individuals as well. Data backups, critical, obviously very important. This is actually, after the earthquake, this is the server for Geskio in Port-au-Prince. and they were propping up the ceiling with various posts. They were able to maintain their backups, but a number of organizations, because they had electronic data with off-site backups, for example, Médecins Sans Frontières, using OpenMRS in Port-au-Prince, were able to reload their backups. So really, really important to have your off-site backups. And our synchronization tools we use in Rwanda actually do that kind of automatically, which is helpful. Confidentiality, as you brought up earlier, a very, very important issue. There are good technical solutions. It's a training issue particularly, and really lack of national policies in many countries, including Haiti, have made it very difficult to know what you can and can't do in these situations. Mobile devices, we're going to talk much more about those. I will not dwell on it. A couple of examples from Haiti, systems that this was actually used in clinics there, and this was a system we developed with some colleagues here to do a screening process for surgical patients, though it didn't actually get used in that form. Finally, I just want to mention the Maternal Concept Lab, and this is what we've been working on with a whole bunch of other organizations. Actually, I think WHO, Gates, PIH, Millennium Villages Project, D3, AMPATH, IDRC, and so on. And they're all working together on a core set of initiatives for supporting maternal health. And this is really an interesting project, and we're looking at how can we actually put together the most important data and screening, what people actually use in terms of published reports and so on, so we can actually identify the most important items. Okay, and we talked about that. Okay, so we're a little short on time, but we had a few conversations. So any more questions?